Of the 500 subjects included in the CTEVD study, 499 were eligible for statistical analysis. One secondary progressive patient was examined twice, and on both exams he was positive and for CCSVI, and only one assessment was used. Of the 374 subjects who were not assessed on, were assessed on all 5 criteria, where 125 were not assessed on criteria number 2, Zamboni criteria number 2, which are deep cerebral veins, because of the technical difficulty we had. So there are 3 terms that we use for the prevalence: those who have the CCSVI certainly, those who do not have CCSVI certainly, and those who are borderline. So 42 subjects in the CTEVD study did not fill any of the 4 other criteria. So even if they would fill that criteria number 2, which we were not able to assess, they would not have, according to the Zamboni criteria, CCSVI. 31 subjects had already 2 or more criteria, and so one missing criteria clearly would not change their diagnosis, and the rest of the 52 subjects had only 1 criteria fulfilled, and they were called borderline. This is a prevalence table showing the prevalence according to the specific of 5 criteria between the 5 groups. And there were 163 normal controls, 21 CIS patients, 26, 30 ONDs, and 289 MS patients. As I told you, the prevalence was done by using the borderline cases as positive or negative, and that's creating 2 different types of prevalences, going from 62 in the MS patients, 45 OND, 42 CIS, and 25% controls. When the borderline cases were included as negative, this was 56, 42, 38, and 22. We also looked at 1 criteria, any of the 5 criteria positive, and that was 55, 76 in CIS patients, 81 in MS patients, and 65 in ONDs. If you look where the highest prevalence was, it was in the criteria number 3 in MS patients, which are intraluminal abnormalities like membranes, FEPs, and FLAPs. We looked the differences by age, comparing pediatric and MS adult patients, and we found no difference. There were 10 pediatric MS patients in this study, and both prevalences were equal, 56%, when the borderline cases were included as negative. In terms of the disease progression and different disease subtypes, there was a clear-cut difference going from relapsing remitting to secondary progressive cases. The highest prevalence was in relapsing secondary progressive patients. It was almost 90%. And this was significantly different. In primary progressive was approaching 70%, and clearly in relapsing remitting was in the low 60s. We also looked, we had of 163 normal controls, we had 115 non-familial healthy controls, and 48 had familial connection, which means genetic connection. There were sister, brother, mother, or daughter. And there was no significant relationship, and we will look more into this in the CTEVD phase 2. One of the most important data comes clearly from specificity, and this is a table again showing sensitivity, specificity, positive, negative, predictive value, and odds ratio. You can see that the borderline excluded or included gave very similar specificity, where there only 1 criteria had very low specificity. I think this is very in line what Professor Zamboni said originally. I would also like to have your attention on specificity of criteria 1, 2, 3, and 4, because when they have been present, they were highly predictive of the CCSVI. The odds ratio was very similar between 4 and 6. On this meeting, we are presenting a number of other studies looking more into correlation with MRI. At 2:30, there is a platform on impairment of drainage in the brain parenchyma in MS patients, a case control study. As Professor Zamboni mentioned, we are presenting a number of studies on a cerebrospinal fluid flow. This morning we presented study on iron deposition and on hypoperfusion of the brain parenchyma. I think let me finish by saying that as the CCSVI proceeds, I think that we should proceed under the ethical conscience guide of research. And just to point a couple of, I think, important things to consider. We have to, continuing this research, balance the patient rights and needs with the prudence and scientific rigor, and I applaud Dr. Miller for already pointing that out. I think that in such type of research, we need to invite and search for ethical oversight, because I don't think that local IRB approvals may be sufficient to ensure that what we are doing is proper and right. In that sense, our team made a decision to contact officially National Multiple Sclerosis Society and to ask for creation of a so-called observational data monitoring task force, which will look on our research and say whether, although it's IRB approved, is right or it's not right. I don't think neither one of us is smart enough to make a right decision for the future. I think another critical point is to ensure that no medical risk occurs to the study participants. In this sense, I think that our research on prevalence of this disease is without risk, but others can comment. We are proceeding with safety pilot treatment studies. We did one with Zamboni, and we are, as we speak, start another one, placebo-controlled one. I think that the steps should be respected of scientific research, and that's we need to first find whether something is safe, then whether it might be effective. And in this sense, clearly, I need to call in question all those people around the world who are providing the open-label treatment without the IRB-approved studies to immediately do so. I think that we need to insist on transparency of the funding. Wherever, according to the American College of Physicians guidelines, wherever the funding is coming from, whether it's from funding agencies, patients, or the payment fees themselves. I think focus should remain on the research, leaving the treatment to the providers accustomed to evaluating these new approaches, and maybe later Professor Zamboni will comment on this, because we need to look on the history and what happened in some other diseases when similar problems have been posted in the past. Finally, I think that this forum is really a first important step in putting together and probably not enough scientists to really begin openly discuss about these issues. And I really thank American Academy of Neurology and NMSS Society for the opportunity again. Thank you very much.